Time for another Puscast. My youngest son says I need to quit using this term pus in everything I do. He thinks it's gross, and everyone seems to misread my license plate as if it has two S's. But nonetheless, I'm sticking with pus. This is another Puscast covering the first 2 weeks of January 2013. Happy New Year. This is brought to you, as always, by Pusware LLC, the publisher of the Infectious Disease Compendium, a Persiflager's Guide, available online, on iTunes, and on the Android store. And also, you can go to edgydoc.com to see my growing multimedia empire. But you're not here to listen to me. Well, you are here to listen to me, but you're here to listen about the medical literature as it applies to infectious diseases for the first 2 weeks of January of the new year. So let's get to the literature, shall we? Most of you are well aware that we're into big-time flu season. It's mostly influenza B and H3N2 this season. What can we expect? Well, I've talked about other studies in the past that show an association between influenza and myocardial infarctions, especially H3N2 strains, which are circulating now. There was another article that looked at the risk of myocardial infarction with influenza and found, again, during flu season, that the older you were, the more likely to have a myocardial infarction during the flu season. And with H1N1, we had it in the spring, summer. And gosh, and by golly, if the myocardial infarction rates did not go up then as well. Also, the older you are, the more likely you are to get an infarction with influenza. That being said, the people who least need to get the flu, i.e. people who will die from it, are also those most unlikely to respond to the vaccine. We do have the high-dose vaccine. In the elderly, it's been shown to lead to higher levels of antibody, which kind of sort of correlates with protection. A similar study is out this month in the Annals of Internal Medicine that demonstrates that HIV patients who get the high-dose influenza vaccine had a higher antibody to influenza as well. Unfortunately, in neither HIV nor the elderly am I aware of any efficacy studies for the high-dose vaccine to demonstrate that subsequently the patients have less influenza, but there is biologic plausibility. Not a lot out about flu in the literature in the last 2 weeks, at least things I want to report. I assume 9 months from now, when this season's flu is come and gone, we'll learn all sorts of interesting things comparing the H3N2 epidemic to the H1N1 epidemic. Compare and contrast. Get out your blue books and start writing. For historical reasons, I don't deal as a rule with chronic hepatitis B or C. That's been a GI disease, so I only pay scant attention to issues relating to hepatitis B and C treatment. I sort of know of them. I will mention some articles out this month, but for deeper insights, you should probably go to the primary literature or talk to your local hepatitis expert. There was an interesting article, though, on a surgeon, an orthopedic surgeon, who had chronic active hepatitis B with a very high viral load. They looked at 232 of his patients and found 2 of them had hepatitis B from him, and they went for genetic matching and found the 2 were identical. This surgeon had chronic hepatitis B and chronic active hepatitis B from an area of great endemicity. And they suggest in the article that since he did not respond to 2 vaccine series with a hepatitis B surface antibody positivity, that at that point he should have been evaluated for hepatitis B. Given the rarity, it's an interesting problem from an infection control point of view. Of course, one of the issues that always comes up is how long do infectious materials exist in the environment? This study looked at hepatitis C in water bottles and found not only did it persist in water bottles for up to 3 weeks, but after emptying the water out and refilling the bottle, hepatitis C was still there. So one would imagine that at least it's not amenable to homeopathic dilutions. But your IV drug users should not be sharing their paraphernalia, including their water bottles. There are a couple of hepatitis C treatment articles, which I will have to admit I don't have a lot of excitement for. One in the New England Journal of Medicine that looked at sofosbuvir plus ribavirin for 12 weeks in untreated hepatitis C patients and found it to be effective. And CID had a systematic review comparing boceprevir versus tenofovir in the treatment of genotype 2-1 hepatitis C. They found that tenofovir was probably better in patients who had relapsed, but there was insufficient evidence to suggest a difference between the two in all comers. I suppose in 7 years I'm going to need to know this stuff for my board, so I guess I'll miss those questions. In case you didn't know it, the president of Gambia is a loon. The president in 2007 said he had a cure for AIDS, which was a remedy of basically boiled herbs. To bolster his plan to kill as many AIDS patients as he possibly can, he's going to open up a hospital in Gambia with the curious number of 1,111 beds that must have some mystical significance to him. And they plan on treating 10,000 AIDS patients every 6 months with natural medicines. And as part of their therapy, they have to give up their antiretroviral therapy. Yes, the president of Gambia is a wackaloon. It's sad that those people are going to have to die needlessly because their president is a loon. Not only is flu going gangbusters in the Pacific Northwest and around the world, but so is norovirus. We've been having a shitload of norovirus. There, I just lost my PG rating. Throughout the Pacific Northwest, closing nursing homes and some hospital units. There is noro all over the world. This winter, 1.1 million people in England have had norovirus. And it would appear that there is a new strain circulating around the world. It's known as the Sydney 2012. I presume this is from Sydney, Australia, where it has been sweeping the world, predominantly in Europe and Japan. But I suppose it will be coming to an oyster near you in the near future. As I keep coming back to, the only good food is deep-fried food. Thank goodness for deep-fried ice cream in Mexican restaurants and Texans. The one good thing they've invented, deep-fried beer. I'm safe for now. The classic teaching in the neutropenic febrile is that they are bacterial or fungal in origin. However, most of the time you do not find a bacteria or fungus in patients with neutropenic fevers. And at least half the time or more you don't get an answer. In this study that was published in PLOS One, they took a bunch of patients who were neutropenic and febrile with a variety of hematologic malignancies, and they found 35% of the subjects by either nasopharyngeal aspirates, 18%, or blood samples, 22%, had viruses. Which viruses? Well, they were BK polyomavirus in 11%, CMV, parvovirus B19, Epstein-Barr, adenovirus, rhinovirus, influenza A, influenza B, metapneumovirus, and several had more than one. So viral etiologies are probably a hitherto underdiagnosed cause of fevers in the neutropenic febrile. Given the ubiquity of some of these viruses in normal people, like CMV, whether it's causal for the fever or not, I do not know. And you can't do anything about most of these anyway, still having to fret about bacterial and fungal infections, which are the things that kill most of these patients. And for you guideline mavens, there's a new guideline out, 4th European Conference on Infections in Leukemia, Guidelines for Diagnosis and Treatment of Human Respiratory Syncytial Virus, Parainfluenza Virus, Metapneumovirus, Rhinovirus, and Coronavirus. Actually, that's coronavirus. Available at a clinical infectious disease near you. In the race to become the first totally resistant microorganism, I think gonorrhea is going to win. For years, I had bet on either Enterococci or Staph aureus, but Enterococci aren't that big a deal, and gonorrhea is. Cefixime resistance is increasing. With higher MICs comes increased failure rates, as documented in JAMA this month. They looked at all the people treated with cefixime and found a 7% failure rate. And that was associated with having MICs to cefixime above 0.12 micrograms per mil. If you had that particular MIC, your failure rates were 25%. This was for urethral, pharyngeal, and rectal gonorrhea. Fortunately, though, it was in Toronto, so the Canadians are the ones having the problems, and I know that nobody ever crosses the Canadian-United States border, so we should be safe. Given over 100 million cases of gonorrhea a year in the United States and increasing resistance to all classes of antibiotics, pretty much are going to be stuck with ertapenem until it's resistant to that. And then, total resistance. As I always say, the Borg had it wrong. Resistance is not futile. Resistance is inevitable. I know the first thing you asked yourself this morning when you woke up was, hey, what's the incubation period for listeriosis? Why would you care? Well, part of the reason is that knowing the incubation period helps you zero in on what the source of the listeria or other infectious disease was. In the world of food-related illnesses, people always blame the most recent meal, where, with the exception of preformed toxins, you need at least a day or two before you start getting ill from a given meal. So this study out of France, which has always been Listeria Central, probably because of the propensity for undercooked food. I love the food of France. They looked at 37 cases of listeriosis, and I will just read the abstract because it has all the answers there. The overall median incubation period of invasive listeriosis was 8 days, range 1 to 67, and it differed depending upon the clinical disease. Pregnancy-associated cases, 27.5 days, range 17 to 67. CNS infections, 9 days, range 1 to 14. And bacteremia, 2 days, range 1 to 12. For gastroenteritis, the incubation period was a mere 24 hours, with a variation between 6, which must have been one hell of an ingestion, and 240 hours. So depending on the type and manifestation of listeriosis, it can be hours to weeks before people become symptomatic for their disease. But just remember, deep fry your food. I don't see a lot of melioidosis here in the United States, but I assume I have a worldwide distribution in listeners. There's probably at least one person listening in, say, Canada. This study in the American Journal of Tropical and Medicine and Hygiene looked at outcomes for patients with melioidosis if they were treated with cotrimoxazole alone or in combination with doxycycline. And they found that cotrimoxazole alone worked just as well, but was better tolerated in a retrospective review of patients who had had melioidosis. There was a recent local outbreak in the United States. I forget the details, but I think it was in Arizona or something along those lines. So it's not entirely unheard of outside of the rice growing zones. For those of you not in the know, melioidosis tends to be found in rice fields. So how long to treat infections is always a big question for an ID specialist. How about Mr. Whipple's disease? Well, this was a study out of the Journal of Infection where patients received 2 weeks of ceftriaxone parenterally and then either received 3 months or 12 months of BID Bactrim, TMP sulfa. And there was no difference in outcomes between the 3-month and 12 months of therapy. Certainly a lot easier to remember to take your meds for 3 months than it is for 12. I mean, I only have to take Thorazine once a day, and I can't remember to do that. Someone mentioned that the one downside to my podcast is my hatred of dogs. Actually, generally speaking, I like dogs. It's dog owners I loathe. because they let their dogs bark incessantly and crap on your yard and run up barking at your small children, etc., etc. But that's neither here nor there. The other reason I like dogs and cats and other animals is they are great vectors for infectious diseases. And of course, I have kids in college and private high school, so it's good to have infections. The study looked at the fecal samples of dogs and cats for Yersinia enterocolitica, and guess what? They found them not infrequently. 4.5% of dogs carried Yersinia enterocolitica, and 0.3% of cat poop contained Yersinia. So add Yersinia to the list of the many bugs for which pets are a potential vector. Tea tree oil is somewhat popular as a topical antiseptic/antibiotic, and I've been impressed with its ability to cause allergic reactions. I've seen a couple people come in with, quote, cellulitis, unquote, that were having an allergic reaction to their tea tree oil. Not an uncommon complication. Is it effective in preventing MRSA? In a study where they compared tea oil, did I say that right? Tea tree oil with Johnson's Baby Soft Wash in an ICU, looking to see if they could prevent MRSA colonization, it didn't work. Quelle surprise. There are different ways of looking at the timing of surgery for endocarditis. Now, there was the recent New England Journal of Medicine randomized trial that showed that early surgery was of benefit for survival compared to later surgery. And there have been retrospective studies that have demonstrated the same thing. One of the results of the New England Journal study was that those who had surgery had fewer strokes. However, surgeons are loath to operate on patients with acute ischemic events. Putting them on bypass and anticoagulation is considered to be a bad thing. This study looked at the timing of cardiac surgery after stroke and found that there was no difference in mortality if they were operated on 7 days after their stroke or before 7 days after their stroke. There was a slight non-significant increase in hospital mortality in patients who were operated on early, but the survival curves were more or less the same. So there does not appear to be a survival benefit in delaying indicated surgery in patients who have endocarditis who have had an ischemic stroke. Increasingly, the data is suggesting that the treatment of choice may well be operative rather than medical in the treatment of native valve endocarditis. Give our surgeons something to do as people quit smoking and they don't need their bypass surgery as much. I have a lot of responsibilities in my job. One of them is infection control. So imagine this. You're being watched by the state. One of your anesthesiologists, and I'm not going to say which of the 6 hospitals I'm responsible for this happened in, is doing a case being watched for his technique. And 4 times, yes, 4 times they access the central line and don't scrub the hub. Now you need to scrub the hub. It prevents contamination of the hub and perhaps bloodstream infections. But the problem, of course, is timing. You have to scrub it for a fair amount of time. You can get by this by putting on disinfecting alcohol caps. But do they work? And the answer is yes. The American Journal of Infection Control, they looked at the results of using a standard scrub versus a cap and found that when patients had the cap on, they had fewer line contaminations, decrease in the organ density, and fewer central line associated bloodstream infections. So, a pretty good outcome. We now use them at most of my hospitals. It's nice to see the benefit is proven, since we did it before we really had any clinical data, because it at least made some biologic plausibility. There's been the ongoing suggestion that antibiotics worsen hemolytic uremic syndrome by E. coli, and that some test tube data shows that when E. coli is exposed to Cipro, it kicks out more toxin. So it was interesting to see that there was a study out of Germany where they looked at the results of patients during their recent E. coli OH157 epidemic and the results of antibiotics. They had a whopping 24 patients who developed the syndrome of diarrhea due to the E. coli. 7 received antibiotics, Cipro, cefotaxime, and amoxicillin, and the rest did not. Of the patients who got antibiotics, 57% developed HUS versus 88% of those who did not. Of those that got Cipro, 40% got HUS versus 89% of those who did not. These were extended spectrum beta-lactamase producing E. coli, so Cipro was the only effective agent. So in this retrospective study suggests that Cipro is actually protective for getting hemolytic uremic syndrome if you had diarrhea from E. coli. In Europe, to be picky, it was O104H4, not OH157, which has been the big one in the United States all these years. But the O104H4, if you gave antibiotics, they were protective. And there was the New England Journal study a while back that suggested macrolides were beneficial as well. So, should you treat toxigenic E. coli with antibiotics because it prevents rather than exacerbates hemolytic uremic syndrome? I don't know. Maybe it depends on the strain. I guess we have more work to do. We being, of course, somebody else. So, what's your odds of salvaging an MRSA infected hip? This series out of Spain looked to be about 55%. They compared their MRSA hip infections with their MSSA infections and found that having the specific bug made no difference, but what did make a difference was having a rifampin-based protocol. So something plus rifampin is important. They also noted that MRSA tended to fail on therapy, while MSSA tended to fail after cessation of therapy, which I think that is the case in my personal experience. There was quite a hodgepodge of antibiotics used as well as durations used. So it's difficult to say what the optimal antibiotic therapy is, except include rifampin. But in all comers, maybe you can salvage the infection about half the time without taking the joint out, which isn't bad for an MRSA infection. This is an interesting meta-analysis in clinical infectious diseases where they looked at the results of giving continuous infusion carbapenems or extended infusions, i.e. over 3 hours instead of the usual 20 to 60 minutes, and found that patients who had continuous infusions or extended infusions of these beta-lactams had better outcomes for both pneumonia, i.e. mortality, and for sepsis, i.e. mortality. Now, this is interesting. These are mainly non-randomized trials, so you never really know. But given that beta-lactams have mostly time-dependent killing, you can see how you might get some benefit under those circumstances, since perhaps you're keeping the levels above killing longer with constant infusion. And unfortunately, meta-analyses are notoriously unreliable for predicting the results of a good, well-controlled, randomized placebo trial. So take the results with the grain of salt substitute that it deserves. An enduring medical myth is you have to double cover Pseudomonas. It's a mantra, sort of like fingering your rosary so you'll get a good outcome. Yet another study is out that shows no benefit of double coverage of Pseudomonas. Now here's the clincher to that. The presumption is that your monotherapy is susceptible. So if you have a patient going south and you put them on monotherapy up front and they are resistant, they'll have a 43% mortality rate. Where if you give them combination therapy but only one of them is appropriate, you'll have a 21.5% mortality rate. So the important thing is when you start antibiotics for Pseudomonas or anything, you may want to, quote, double cover up front, mostly so that you have backup in case your one antibiotic is resistant. But otherwise, Pseudomonas does not require double coverage most of the time, as it doesn't decrease morbidity, it doesn't decrease mortality, it does increase cost, it doesn't alter outcome, and it doesn't prevent the emergence of resistance. But it does mess with the pharmacy budget, and be nice to your pharmacists. There is a study out this month that looked at continuous beta-lactam antibiotics in severe sepsis. It had the magic words double-blind, randomized, and those who got the continuous infusion beta-lactams of either piptazo, meropenem, or ticarclavulanate had decreased mortality compared to patients who got standard antibiotics, although it was a small number of patients, a total of 60. But more rationale that we should be giving continuous infusion beta-lactams to our patients in the hospital. Now, I spend time in the anti-vaccine world, and one of the things that vaccines allegedly do is cause SIDS, not just autism, but sudden infant death syndrome. What causes SIDS? Well, this was an interesting study that looked at 128 infants whose mean age was 101 days, who died suddenly and unexpectedly. And at autopsy, virtually all of them had pneumocystis with increased mucus expression, suggesting perhaps that the cause of death was acquisition and infection with pneumocystis. Very interesting. I'm sure they'll say that the vaccines caused the pneumocystis, which caused the sudden infant death. But it's a curious association that will need to be further investigated. One of the interesting things to come out in the last decade has been the interaction of the human microbiome and its association with various disease states. I usually don't do pediatric stuff in this podcast since I'm not a pediatrician, but it's interesting that they found kids who had colic had less microbial diversity and stability than their healthy counterparts, suggesting that it may be an abnormal microbiome that leads to children getting colic. And a few things are as gagalicious as the concept of a stool transplant. There is now a synthetic stool. I think this comes out of Washington, D.C., that is also of benefit in a few number of patients for the treatment of C. difficile. Given the superiority of microbial transplant for C. diff, it sure would be nice to have a synthetic equivalent that we could give patients. It would sure be a lot less distasteful. We could just call it, the Uber probiotic for your C. difficile. And sometimes you just have to quote the title of an article. This is from PLOS, Neglected in Tropical Diseases, and looked at the pattern of schistosoma in hookworm eggs in fecal samples. And they were not uniformly distributed, suggesting that you should homogenize the stool and keep them on ice because they degenerate to help increase the accuracy of diagnosis. However, I love the title. An in-depth analysis of a piece of shit. Distribution of schistosoma mansonii in hookworm eggs in human stool. It is a title for the ages. A while back, I had a patient who came in with a gastric obstruction, and it was a phytobiozar. She liked to eat lots and lots of Chinese mushrooms, and they coalesced into a big ball that obstructed her GI tract. What to do? It turns out that Coke adds life in multiple ways. Not only will Coke increase the absorption of itraconazole should you need it, but Coca-Cola, not cocaine, helps dissolve phytobiozars. Everybody in school has put a nail into Coca-Cola and watch it rust away. That's not the same mechanism, of course, but Coca-Cola is a good way to get rid of the phytobiozar in up to 90% of patients. I'm a little pooped, and I think I'm going to bring this to an end. I'm on call this weekend. I was sick earlier in the week, and I'm running out of energy. But I still think you have everything you need to know in the last 2 weeks. As always, you can go to my website, edgydoc.com, to find links to my growing multimedia empire. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall follow along with you, but have no clue as to what's going on because I'll be damned if I can figure out the EMR. Thank you. In dictation. Goodbye.